murmurs and malformations in kids here. You're going to run into quite a few murmurs in kids. It says here 50%, and that's not an overestimation. Young kids, especially newborns, within a few days after birth, have murmurs quite often. What you have to distinguish, though, is the difference between an innocent murmur versus a pathologic murmur. And innocent murmurs are most commonly due to the reasons that you see right there. The other thing that you would say an innocent murmur would be like a very small PDA that today is there and tomorrow it's gone, that's asymptomatic. You know, I'd consider that an innocent murmur as well. But other than the things like the angulated great vessels and more dynamic circulation, that says there's not a congenital heart defect, but a PDA is. So, but if it closes up, you're fine. Okay? Just a matter of semantics, like Bill Clinton. Okay. Pathologic murmurs, these are the things you need to remember right here. If you encounter these are 99.99999% always, with the exception of that 0.0001% pathologic. Any diastolic murmur in a kid or adult is pathologic. Any diastolic murmur. Pansystolic murmurs, when you can hear that murmur, when the whole S1 to S2 is obliterated by the sound of the murmur, that's pathologic. That says there's when you have a valve dysfunction, whether it be stenosis or regurg, you understand that you've got to generate pressure to generate the abnormal sound. So there'll always be a gap between S1 and the beginning of the murmur. Or it'll start out very quiet and then crescendo as blood is forced through the murmur with increasing pressure, and then as pressure falls in the ventricle, it comes back down, deep crescendo. But any pansystolic murmur, in other words, you're listening to it in this shh, 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 that is pathologic. And that means there's a big hole somewhere, okay? By the way, the first week of December, when we start doing the skills development, I'm going to get a stethoscope from a company that has tons of sounds in it. So you put it on and you hear the sound. So we'll have it all that week. Make sure you get your time on that stethoscope. Okay? The other ones, late systolic, loud murmurs, any loud murmur, that's obvious. Continuous murmurs mean all the way through the cycle. And you have a hard time distinguishing the S1, S2. Now, history of people with pathologic murmurs here. The thing that you wind up with, or the end game, is pulmonary edema. Pulmonary edema due to low cardiac output because of the murmur. Either a stenotic or a regurgitant or a hole is going to back blood up in the pulmonary circulation. You're going to wind up with pulmonary, not only pulmonary edema, but over time, destruction of the pulmonary architecture, and it's just going to go from bad to worse if it's a pathologic murmur. In kids, in little kids, infants, what you're looking for is, or what should raise your suspicion here, is this is not an innocent murmur, this is pathologic, is failure to thrive. they don't, and failure to thrive just basically means poor weight gain. You know, you learn from OBGYN that, well, maybe you're doing it now in pediatrics, that when a baby is born, so the birth weight is, say, 8 pounds. There's a couple of weeks there before that baby comes back up to 8 pounds. They're going to drop weight, they're going to get down to 6 pounds, and then they're going to slowly gain weight again. And so your target is to have them regain their birth weight by, I can't remember what it is, like 2 or 3 weeks. But if they don't regain their birth weight, or they're not on an appropriate trajectory, you need to be thinking about failure to thrive. Failure to thrive goes back to feeding. And the problem with feeding is it takes so much energy, and their mouth is not open to breathe air to accommodate for the decreased pulmonary function. It's just a spiral. Okay? So any kid that has a failure to thrive, the differential there is quite large, from cleft palate, cleft lip, to abuse, to something like this, to a GI anomaly. But an echo is always in the workup for failure to thrive. So here we go. If you look at this little kid, when you have venous congestion because of poor cardiac output, the color of hemoglobin is blue. That's why you become cyanotic. And you can see on this kid the circumoral pallor, or circumoral cyanosis here. I don't know if you can tell from your computer, but this kid's hands are also blue. So this is a kid in trouble. Physical examination, you should pay quite a bit of attention to that. In addition to the physical signs that we've talked about before, capillary refill, pulses, central pulses versus peripheral pulses. Central pulses in an infant or newborn are the brachial and ephemeral. Peripheral pulses would be radial and pedal. I had a physical exam last week by a nurse practitioner because I get a physical exam every 5 years, whether I need it or not. And I've always had them done by physicians, and they were horrible physical exams. Horrible. I mean, I would have failed that had they been the student, right? So I said, well, I'll change doctors. So I went to this guy down the road here, but I wound up with his nurse practitioner. Do you want me to show you the entire physical exam this woman did on me? Do you want me to show you? Okay, here we go. Anybody have a stethoscope I can borrow for a second? So if you ever do this, I will beat your ass. I go in there and I tell them that a month ago, when I was scuba diving, I had to snorkel out about 150 yards with the full gear. It was against the tide, it was in the wind. I felt chest pain. And I'm pretty sure it was angina. As soon as I stopped or slowed down, it went away, it's never come back. But I'm pretty sure that was angina. Now, a 60-year-old guy that says, I have chest pain, I had chest pain, an incident of chest pain. Now, I would rate it maybe a 1 out of 10. It was very mild, but nonetheless, I think that's what it was. That should alert you that something is not right. This was last Friday. To this date, I have still not had an EKG. I have received no nitroglycerin in case I have an MI, nothing. Okay, I'm going to show you the entire physical this woman did on me. A new patient to the practice. Andrew, could I use you in this example? If you'll come over here. Put your feet there. Here's the entire physical. Okay? Open your mouth. Okay? I'm feeling the submandibular region. Okay? Okay? She had her stethoscope in. Deep breath. Again. 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 Okay, breathe normally. Lie back. Sit up. Okay, that's it. Thank you, sir. That was the entire, that was the complete, what are you here for? I am here for a complete physical exam. That was her, notice, I never took my clothes, I never did it. I was actually wearing this shirt. It stayed tucked in the whole time. And everything was listened through my shirt. That was I will beat your ass. So, physical examination. The gecko that you see on the hand, on the right there, you're not going to, you'd be hard pressed to see that. Because that's a very chronic condition over years. No one will let that get that way now. Although, in people with cystic fibrosis, you're going to see clubbing in kids with cystic fibrosis. Congenital heart defects that would cause that are going to be repaired. Cystic fibrosis, though, you're going to have to endure that. Okay. Congenital heart defects. Divided into two categories, either acyanotic or cyanotic. And that depends on left to right or right to left shunting. And that's what you need to keep in mind whenever on a test question or you see a patient, is this a left to right or right to left shunt? Now remember, anything that goes from right to left, right heart to left heart, is going to shunt blood away from the lungs. So that's going to be cyanotic. Shunting blood from the left side to the right side is obviously not. What you may find with a left to right shunt, though, is poor perfusion of the periphery. Okay, we'll get into that later on. The incidence of congenital heart defects is pretty low. I mean, if you stop and think about it, 1%, that's actually, I would say, pretty high. 1% of all births are going to have some form of congenital heart defect. If you look at the distribution of heart defect, the overwhelming majority are VSDs. VSDs, and then all of the rest of them are pretty much level. Now, understand that things like tetralogy of Fallot and TGA, transposition of the great arteries, the incidence there is about as high as, CoARC or an ASD. So it's pretty high. Once you get away from VSDs, all the rest of them, the incidence is pretty level across there. Okay? All right, so the acyanotic congenital heart disease. Just stop thinking about these for a minute. Acyanotic. Okay. A VSD, where's the direction of blood flow going in a VSD? Where's the high pressure chamber? It's the left side, putting blood to the right. How about an ASD? Same thing. High pressure on the right, the left, blood going to the right. A PDA. Where's the high pressure in a PDA? In a born kid? The high pressure is in the aorta, so the direction of blood flow in a PDA is counter to what it was as an embryo. You're putting blood from the systemic circulation, the aorta, into the pulmonary circulation, the pulmonary arteries. That's why PDA is an acyanotic event. Okay? And then you get into vessels and valves, pulmonary stenosis, aortic stenosis, CoARC, mitral stenosis, and Epstein's anomaly. We'll talk about these things later on. Epstein's anomaly is This is something I did last night, so sorry about that. Epstein's anomaly is a transposition of the tricuspid leaflets into the right ventricle. So normally they're up here in Epstein's, they're down here in the bottom. So you have a sort of a hypoplastic right ventricle. You got this ginormous right atrium. Okay. I've never seen a case of that, but it's on the list. Okay. So let's talk about VSDs here. VSDs, to just point out the VSDs, there's your septum there, the muscular septum, so the membranous part would be up here. The defects, according to the literature, can be either in the muscular portion or the membranous portion. As I said yesterday, they're overwhelmingly in the membranous portion. Although, if they occur in the muscular portion, they tend to spontaneously heal faster than membranous issues. Most of the defects of the VSD, as I said here, will go away or cover up on their own by school age. So that's the general year that you're looking at. If you look at the types of VSDs, basically they're small, medium, large. So a small, if you look at 3, 5, and 10 millimeters, that will give you an estimate of the small, medium, large. The closure here, 90% of them will close by school age. So that's good, of the small ones. Okay. The moderates and the large ones, moderates may have to be repaired, but the large ones always have to be repaired. For two reasons. One is because you're going to wind up with ventricular hypertrophy if you don't repair it. The repair of a VSD is usually done with a catheter. It's not an open procedure. It's usually done with a cardiac catheterization. The pathophysiology here of a VSD is basically, it has to do with ventricular hypertrophy and leading to pulmonary or cor pulmonale and downstream effects. The clinical findings of a VSD, again, are going, since it's an acyanotic issue, you're not going to be looking for cyanosis of the skin. You're going to be looking for perfusion, more perfusion-related defects. The murmur of a VSD is pansystolic. Because the hole is there, you're not having to generate pressure to go through a valve. The hole is just there. Okay? And unlike an ASD, a VSD murmur is due to blood, the turbulence of blood going through the hole. An ASD is not like that. The VSD is the turbulence of the hole that generates the murmur. If you look on x-rays, the heart is enlarged, and where it says the lung fields are over-circulated, that's because you're pumping oxygenated left ventricular blood back into the pulmonary circulation, so you'll have prominent vascular markings out here in the lung parenchyma. Always pay attention in kids to the perfusion of the lungs, because in congenital heart diseases, they're either over-perfused or under-perfused. And that will give you a clue as to what you're dealing with. Okay, so in left to right shunts, they're always over-perfused. In right to left, they're under-perfused. ASDs come in 3 varieties, and I mentioned these yesterday. You have defects of the foramen primum, the foramen ovale, And they call it right here the secundum, but it's essentially the foraminal valve. And then last I was talking about yesterday, since the atria start inferiorly and are transposed up, the sinus venosus is that connection between the atria and the veins. And that's the last place that they can occur. Of course, the most common place for them to occur is going to be at the foraminal valve, which is a naturally occurring hole anyway. The pathophysiology here is sort of the same between ASDs and VSDs. There are a couple of other problems here that you need to pick up, or you need to understand though. With an ASD, it says right here, may have atrial dysrhythmias. You got to remember that if here is your foraminal valve, and here's the defect, the SA node sits right there, the AV node sits right there. So the normal conduction pattern between the two can be disrupted by the presence of this hole. And that's what they're talking about there. The murmur, it says right here, is again not due to the blood going through the hole, but because the pulmonary valve is sitting right there, it's the volume of blood entering the pulmonary circulation through the pulmonary valve that causes the murmur.
On the last slide, you have RAE and RVE. What does that mean? Enlargement?
Right atrial enlargement and right ventricular enlargement. Simply because of the increased volume of blood. Okay. And core pulmonary. So I maybe didn't stress this enough. I said you're going to have pulmonary edema. That's going to lead to a cardiac effect. That's core pulmonale. So when it says CHF here, that's essentially core pulmonale. I mean, you tend to save core pulmonale for the emphysemics and the chronic bronchitis guys, but that's essentially what it is here. The ASDs, these things are, I picked up a lot more ASDs than VSDs, although VSDs are more common. I don't know if because they have a higher rate of closure, auto closure, or what, but ASDs are pretty common in the adult population. It's a soft murmur. It's only 1 to 3, usually more around 1. But you're going to confirm it. The echo will confirm it for you. It's pretty easy with confirming it. The vascular markings here, again, are going to increase because it's a left to right shunt. Now, repair of ASDs, again, is done with a catheterization. You can see the large ASD right here. That's pretty impressive. I mean, that looks like a totally open foraminal valve. And you just go in there and put a patch on it like that and can close it up pretty easily. Okay. PDAs. Now, you know what a PDA is. Closure of a ductus arteriosus usually occurs within the first 3 or so days after birth. 3 or so days after birth. Most kids that are born, if you are good at auscultation, you're going to pick up that murmur. It's very soft. They actually listen for it in the back, not in the front. prostaglandins are what closes it. We talked about prostaglandins, I believe, prostaglandin E2 with the fetal circulation. When we get into some of the congenital malformations here, you're going to see that you have to have that PDA in order to survive. So these kids, you don't want that PDA to close. You're going to stay away from, I don't know where it is. You're going to stay away from NSAIDs, and you're going to have them on prostaglandins to keep it open. There's a couple of interesting things. Higher altitude females increase the likelihood of a PDA. If it's there and if it remains, it usually is a signal that there are some other problems associated with it. So if that murmur is still there 3 to 5 days after birth, that kid needs to be echoed. It may be desirable is the ductal dependent issue.
For the defects that overperfuse the lungs, do they have a higher pressure of oxygen, or do they not get that far?
I'm sorry, what was the?
For patients with the defects that, so if you're sending more blood to the lungs, do they end up with a higher pressure into, or does it not get that far because the heart's not working?
Higher pressure of.
Like, are they over-oxygenated?
You mean if you measured that PaO2,
Right.
would it be higher? I don't think so. I would think so.
What about the respirations? Would it affect that either? Because I know like the amount of O2 in the blood is measured somewhere else, but since they're hyperoxygenating that blood, would they like slow down the respiration rate, leading to increased or decreased perfusion elsewhere?
Well, you have to remember that you're increasing blood volume to the lungs, but that doesn't necessarily translate into hyperoxygenation, because now you've got alveoli that are flooded with these varicose. So actually, the oxygenation is not enhanced. And to that extent, if you don't do something about it, that pulmonary congestion is going to lead to lung damage. So I think that's a better way to describe it, to say pulmonary congestion. It's not pulmonary edema initially. It is pulmonary, it does result in pulmonary edema if you don't do something about it. Now, pulmonary edema is referring more towards fluid in the alveolar spaces versus pulmonary congestion, which just means what our cases are here. Okay? So the pathophysiology, again, it's correctly said, it's a left to right jump in a PDA by itself. So the problem with this is that you wind up with a decreased blood flow to everything else if it's big enough. So you're going to hyperperfuse anything downstream. It won't affect the upper extremities up. It's downstream, the kidneys in particular, and the GI tract. So I don't know why. I tried to find this last night, but a PDA, a persistent PDA, increases your risk for pericarditis, endocarditis, but I couldn't find that relationship. So, anyway. Pulmonary vascular disease later in life is gets back to what we were talking about. Diagnose this. This is diagnosed early on with echo. Yes, ma'am.
So you said that it'll have decreased perfusion to like your organs and everything. Why not to your arms and everything after?
Because the brachiocephalic artery, the carotid, and the subclavian have already given off, as well as the coronary arteries. The heart's not at risk, but everything downstream, particularly your kidneys, are going to be affected, if it's large. Most people with a PDA that I picked up, they didn't even know they had it. So, you know, you have to think through this. If you're doing a high school pre-participation sports physical on a kid, and you pick up a murmur, one of the questions on the form is, can you keep up with your classmates or teammates? If you're not perfusing your skeletal muscles, they tire easily. So when you're doing your physical exam and you pick up a murmur, this is one thing you need to consider. Is there a PDA here? So, I mean, anytime you pick up a murmur on a high school pre-participation sports physical, you're bound to get EKG, a 12-lead EKG, and an echo. Don't pass them if they have a murmur. Okay? The sound here is like a washing machine. You know how a washing machine goes? That's what it sounds like. Here's the issue about how to treat it, or very few of these ever go to surgery. Very few of these ever go to surgery. And if they go to surgery, it's not a crack the chest, you know, split the sternum to get down there. It's usually done through the keyhole type of procedure where they just go a small, like a knee arthroscopic thing, they go through the chest to take care of this. Now, pulmonary stenosis. Okay, so here we go with some bad stuff. All right, pulmonary stenosis is, it says right there in the first bullet point, pulmonary artery narrowing. It's not necessarily the pulmonary valve. It can be the artery itself. And you see here, there's the valve, there's the stenosis is above the valve. That's one thing you have to be aware of. It doesn't necessarily involve the valve. But anytime you restrict blood outflow from the right ventricle, you're going to expect right ventricular hypertrophy, just like if you have aortic stenosis on the other side with left ventricular hypertrophy. Okay? Right ventricular failure. How is right ventricular failure going to present clinically?
JVD, pulmonary edema.
Yeah, pitting edema of the dependent extremities. You said pulmonary edema?
Yeah, I think it's wrong.
Is this a hyper or hypoperfusion of the lungs?
Hypo.
Hypo, because of the stenosis. Clinical findings, cyanosis from poor oxygenation, from the hypoperfusion. High-pitched systolic ejection murmur. So when you start thinking about these murmurs, why is it systolic? You know, if I ask you, which of the following would produce a systolic murmur? Okay, so if the ventricles contract, anything going on with a pulmonary valve or aortic valve is going to be on. Also, any regurgitation through the tricuspid and mitral valve will produce a noise in systole. All right? So those four problems are systolic murmurs. Pulmonary and aortic stenosis, and mitral and tricuspid regurg. Mitral and tricuspid stenosis would be diastolic murmurs, right? Because There, you have stenotic valves that are gonna make a noise when the atria are contracting, which means the ventricle is in diastole. So I'm telling you, on the board exam, you're gonna have at least 4 questions related to this. And if you just stop and put your, back up from the computer and just, okay, what's going on to produce this murmur? You can figure them out. Now, you also need to know the character of the murmur. The washing machine with a PDA. This is, it says, ejection murmur. And an ejection murmur is meaning you have to build pressure to hear it. So it's going to be a like that, or I'm pretty good at this. So you have to build pressure. Okay. It says there's an ejection click. That's what you would hear if the stenosis involves the valve. If it's supravalvular or infravalvular, you're not going to hear the click.
Is the click when it opens or when it shuts down again?
It's when it opens.
Okay.
Okay. Pulmonary stenosis, normal size heart on x-ray, easy to pick up with echo. To repair pulmonary stenosis, you have to determine where the stenosis is and address it. If it's infravalvular, like an overgrowth of the muscular portion of the heart, you just go in and remove it, cut it out. If it's supravalvular, you can balloon it or repair it surgically. If it's the valve itself, same thing, okay? Right here. If the valve is the issue, valvuloplasty is the way to do it. And this, most of the time, is done with a scope. Or a catheter, not a scope, a catheter. When I say you have open heart surgery means you've cracked the chest and you've cut open the heart. A CABG is not open heart surgery because you haven't opened the heart. This is not open heart surgery. Aortic stenosis is just the same thing on the other side. You see the valve here, there's a stenotic region of the aorta right there. Now, in aortic stenosis, you're talking about a decrease in cardiac output. A decrease in cardiac output is going to produce pulmonary congestion, right? If you're not pumping out the ejection fraction you need, it's going to back up into the lungs. Will you have dependent edema with a left-sided problem? You eventually will, but not initially. But you will have pulmonary issues like pulmonary effusion, pulmonary edema. One of the issues here about aortic stenosis is that because the issue is right here, it can impact the SA node. And that's why they're talking about AFib is a commonly occurred with that. Also, just while we're at it, I don't think I'm going to actually get to it because it's more of an adult situation. A defect in the tricuspid valve, which is right there, is going to impact the AV node, so you might wind up with some weird blocks. Aortic stenosis on the chest x-ray. Left ventricular hypertrophy is the early developing sign. You get an ejection click also on the aortic side. Any stenotic valve can give you an ejection click. And I didn't say it before, but pulmonary stenosis, remember PA up here, right? So right second intercostal space, left intercostal space, do this. A thrill at the suprasternal notch here is kind of feels like when you have this, as the blood is being forced through the stenotic area, it feels like you put your finger there. That's what it feels like. It's not quite as pronounced as that, but it feels like there's a vibration right here inside your sternal notch. And low volume pulses for obvious reasons. The repair of this is kind of interesting here. This can be done with a catheter, but if it doesn't work, you're going to have to go in and replace the valve. The Ross procedure is kind of cool, because what you do there is you take, so your important valve is your aortic valve. The pulmonic valve is not so important. The aortic valve is the most important one. Well, the Ross procedure is you take the pulmonic valve and now make it the aortic valve. And then take a cadaver valve or a mechanical valve and put it over on the pulmonary side. So if that valve fails, the pulmonary side valve fails, no big deal. The aortic valve is the one that's important. Okay, that's kind of cool. Whoever had the balls to do that for the first time was, I mean, pretty impressive. Okay. Coarc. Males have the coarc here, and most coarcs occur right there at the, right around the level of the PDA. Not all of them, but most of them, high percentage of them will occur there at that location. Meaning that the blood supply to the upper extremities and to the head have already been given off. It won't be affected. Just downstream stuff will. If these things develop or persist over time, it says right here, you develop an extensive amount of collateralization around it. And you do that through the intercostals and so basically. The coarc, there are a couple of them that we've seen here. Keep this in mind here. This one right here, because right here you almost have no blood flow into that part. So if this is the case, you have to have that PDA open to feed the lower extremities. This is an example of where you do not want that to close. Obviously, at the present, CHF would be a common sequelae. And then this is the point about the PDA. Clinical findings is you're going to have a mismatch between the radial pulses and the femoral pulses. I guess that nurse practitioner felt like since I had 2 radial pulses, that was good enough. I just can't believe that. That was your whole, I mean, I kept my shoes on.
Did you say anything to her?
Huh?
Did she know that you were a provider?
Well, so my blood pressure was up that they measured through my shirt. And I had taken it the week before over in Good Shepherd. It was kind of borderline. And so she said, well, I think we're gonna have to, we'll get some lab on you. We'll get some lab on you. And we're gonna start you on a blood pressure medicine, okay? So she has one reading. It was 146 over 95 to my shirt. One reading. So she said, I'm gonna write you for hydrochlorothiazide. I said, well, I'd rather not take a diuretic. And I was thinking more of something like a calcium channel blocker. And she said, well, how about an ACE inhibitor? And I said, well, first of all, if I'm a layperson, I don't know what the hell an ACE inhibitor is. I said, I'd rather not mess with the angiotensin-renin system. Which I'm not sure she knew what I was talking about. And she said, oh, okay, well, all right. How about Norvasc? I said, well, that'd be fine. She said, are you healthcare? Are you in healthcare? I said, yes. How about Norvasc? Okay, that's fine. Had no idea. I could have been a phlebotomist. And here I'm telling the provider that I want a calcium channel blocker and not, you know, what's number one on the JNC8. Not that, I was really disappointed. I was really disappointed. So I got a prescription for Norvasc, 5 milligrams. And you know when my follow-up appointment is? I don't have one. There's no follow-up. She wrote for a year of Norvasc. 3 months with 3 refills, and there's no follow-up whatsoever. I'm telling you, if you do that, and I find out, I'm gonna be really, I mean, this stick is gonna
Did you see the AHA lowered the blood pressure recommendation?
Yeah, they changed the blood pressure.
I was wondering what you thought about that.
I can't find the 60-year-old recommendation, the recommendation for a 60-year-old. They had say for less than 45 years old, it should be this, and I can't find what the recommendation is for 60. In the JNC8, they make remember, they make a distinction between up to 60, and then they give you 5 more points. So I'm really borderline if you look at JNC8. So, but to provide a year's worth of antihypertensive medication for 1 blood pressure reading with no follow-up, no EKG. I mean, what if I had Wolff-Parkinson White and you're putting me on a calcium channel blocker? That can result in DED. You don't even have an EKG. Never put somebody on an antihypertensive without doing a 12-lead EKG. Never. Not even hydrochlorothiazide. It's just the most insane thing I've ever seen. So, I'll give you a break here. So here's the thing that I want you to talk to Dr. Britton about. My really main concern here is I want to get an exercise treadmill test. And they said, well, we'll set that up for you. A 60-year-old guy who said he had chest pain, in my mind, the exercise treadmill test would have been on Monday. So when they called yesterday for the lab results, I said, you guys were going to set up an exercise treadmill test. Yeah, we're working on that. We're now 6 days later. Okay? I still don't know anything about when this test, you know, if it's going to happen. So anyway, besides the exercise treadmill test, the PSA is what I was interested in. It's kind of funny. She was a hot little number. So after she finished her comprehensive physical exam, you know, we get to the point of a rectal exam. So I'm just dying to see how she's going to work her way out of this. And she did this right. She said, you know, the current recommendation is not to do a rectal exam if you don't have prostate signs. I said, I do not have prostate signs. No decreased force of stream, no hesitation, no unusual nocturia, So she said, okay, well, if you want, we'll forego that. I said, well, that'd be fine. The problem with that statement, that exchange right there, is this was before knowing that I was in healthcare. What is a prostate sign? Like something to hold up? What is a prostate? I mean, that completely, and I said no. I didn't say, no, I'm not having these things. I just said no. So that was the not having to do the prostate exam was fine, but why she didn't have to do it was totally wrong. Anyway, here's the thing so Dr. Britton, so my PSA came back like 1.5. So Britton is going today for his whatever, he's getting a PSA. So it's kind of like a manly. I want my PSA to be real higher than his little wimpy PSA. So when you see him, say something to him about, oh, I heard Neil's PSA was more manly than yours. Let's take a break.